Okay, I'm recording now. Good evening, everyone. So we are going to have our lecture on dyslipidemia. Okay, our learning outcomes. Yeah, that we will review the pathophysiology, general approach to management, aspect of pharmacotherapy and pharmacy practice, and also apply the knowledge to solve cases. Okay, I think this one is very basic, yeah. Hyperlipidemia, hypercholesterolemia, dyslipidemia. So some books prefer to use dyslipidemia because you know that for hyper, not all we don't want to be hyper, yeah. For example, LDL, of course, we want to be low, but HDL, we want HDL to be high, yeah. So if we say hyperlipidemia, it's wrong because in this case the HDL is low, yeah. If the HDL is low, so it's not hyper, right? So we some experts prefer to use dyslipidemia, yeah. That's why they use dyslipidemia, okay. And also metabolic syndrome. Okay, dyslipidemia refers to the following lipid levels. Yeah, this is according to Malaysian guideline. Yeah, total cholesterol more than 5.2, HDL less than 1, that is for male, and less than 1.2 for females, and TG triglyceride more than 1.7, and LDL's cholesterol will depend on the patient's CV cardiovascular risk. Yeah, so we have got this lipid profile. Yeah, so in the past, if you look at the lab test results for each patient, normally the lab will give the result for LDL, HDL in the bracket. Yeah, the the normal range, yeah. So that is only for quick comparison, yeah, quick reference. But in pharmacotherapy we have our own definition, yeah. So criteria, yeah. And different cardiovascular risks have different LDL criteria, okay. And even in the UK, they like to use ratio between total cholesterol and HDL. Yeah, that if you follow the UK guideline, like NICE guideline, yeah, so they always mention total cholesterol, ratio of total cholesterol over HDL. Now, when we talk about lipid, actually there are three kinds. Yeah, the first one is triglyceride, which is fat and oil. Okay, phospholipid, lecithin, and sterol, which are cholesterol. Yeah, and if you go to the supermarket, you will see all this oil. Yeah, they put like the palm oil. Yeah, they put no cholesterol. Okay, so it can be deceiving. Yeah, because there is no cholesterol in this oil. Yeah, they are rich in triglyceride. Yeah, triglyceride, yeah, triglyceride, yeah, triglyceride. But actually the triglyceride, yeah, provide fatty acid, yeah, and then this fatty acid can be converted, yeah, to acetyl CoA, and then the acetyl CoA converted to cholesterol. Okay, although they don't contain cholesterol, but they can make cholesterol, yeah, synthesis cholesterol. Okay, so when you talk about triglyceride, yeah, so it's basically glycerol plus the fatty acids, yeah, become triglyceride. I think I don't have to talk so much about this because you have basic already, yeah. So what is the role of triglyceride? Triglyceride, yeah, is triglyceride is store and distribute energy. Yeah, example, triglyceride steroid, yeah, is C17. Okay, And cholesterol, the sources of cholesterol, 80% from food, 20% synthesized in the liver. Okay, the functions, as we know, component to make cell membrane and precursor of steroid hormone, vitamin D, and bile acids. Yeah, like hormone like estrogen, yeah, bile salts, they are from the cholesterol. Okay, and metabolism of triglyceride. Okay, we have, so the triglyceride here, yeah, um, okay, so triglyceride can produce acetyl CoA, or acetyl CoA here, acetyl CoA, yeah. So triglyceride being lipolysis, yeah, and then will provide fatty acid, yeah, and then the fatty acid, okay, will produce later on acyl CoA, and the acyl CoA can be used for energy, yeah, Krebs cycle can be used for energy, right? And then when you see the acetyl CoA here from fatty acid, yeah, can be used to synthesize cholesterol, okay, and also the actually glucose, yeah, can also form acetyl CoA, yeah. So precursor of cholesterol, acetyl CoA can be produced from glucose and fatty acids. So high intake of fats and sugar can increase the cholesterol. Yeah, so they are intercorrelated. So our case here, Alex, a 48-year-old man, came to KK after being advised by a community pharmacist. Last week, he visited a community pharmacy and had a random blood sugar test, and the result was 13. So the blood sugar is high, yeah, 13. Okay. Below are his medical history, social history, physical examination, and lab results. Okay. So body weight 70, height 165. We can calculate the BMI. Yeah. And smokes half package a day since the age of 20. Denied drinking alcohol. Occupation sundry shop owner. Married, having 2 children, aged 10 and 7. Family history, his father passed away at the age of 54 due to heart attack. Yeah, he had a history, so the father, yeah, had a history of T2DM, type 2DM, and hypertension. His mother is still alive, age 65, suffering from hypertension, type 2DM, and dyslipidemia. So from the family history, we know that he has a strong history of diabetes and hypertension. Yeah, so he probably will have a very high risk, yeah, high risk of CVD. So continued allergy and KDA, yeah, PMH, past medical history, nothing significant except for dengue fever 5 years ago. Medication history, not on any chronic medicine. Vital sign, the BP, yeah, BP is quite high, and then heart rate 70 beats per minute, respiratory rate, and the temperature 37. Physical examination, he has got suntail asthma, yeah, so these two suntail asthma in both eyes, but no arcus senilis and any forms of xanthoma. You know what is arcus senilis, yeah? So if you see the eye, but this eye is closed, but the eye have to open, yeah? So you will see around the uh, pupil, yeah? You can see the kind of halo, yeah, white color. So this is called arcus senilis, which we normally observe in elderly. Now, so why it is important, this suntail asthma? Yeah, because we can see that these are the signs of hypercholesterolemia. Yeah, palmar xanthoma or striatal xanthomata, palm creases in English. Okay, so these are deposition of the fat and cholesterol, And then we have arcus senilis, now I mentioned arcus senilis, yeah, or corneal arcus. So it's an arc, yeah. Arcus means arc, yeah. So the arc. Senilis means for the elderly, yeah. So normally you see it in the elderly, but if you see it in the young person, so it means this person has deposition of cholesterol, yeah, the high cholesterol. Okay. So they have central asthma, which is deposition of lipid layer, and they have central asthma. Okay, and then we have got tendon xanthoma or Achilles tendon and finger extensor. So you can have this tendon xanthoma. Yeah, you can see the tendon here got some elevation. Yeah, xanthoma. Okay, and then we have got, see the eruptive xanthoma. Yeah, eruptive xanthoma. You have seen people with this. Yeah, all right. Especially the central asthma, yeah, is quite prominent, quite easy to capture, easy to observe. Okay, for the lab test, sodium normal, potassium a bit low, yeah, chloride normal, um, serum creatinine, yeah, is normal, urea, fasting plasma glucose is high, A1C is high, yeah, total cholesterol 6.2, yeah, so we want it to be less than 5.2. So this is what I see, and I say, yeah, these are the um, reference, yeah, is just for the reference, yeah, and then triglycerides, and then AST, ALT, I highlight, yeah, I highlighted because later on it is important. So this still okay, yeah, still within normal limits. Now, questions. LDA is not available in the lab results. Could we find out the LDL by calculation? So actually, the LDL that we obtain in the lab test, from the lab, they are not being measured in the lab, but they are also being calculated by the machine. Okay, I took away the LDL so that we can learn the calculation. Okay, this is called Friedewald's equation. Yeah, the LDL equal to total cholesterol minus HDL. Yeah, actually minus again triglyceride divided by 2.2, or if we put it under bracket, so it's plus lah. Yeah, so the total cholesterol minus this, yeah. So we get 4.15. Okay, so this is from the lab, yeah, normal less than 3.4, but actually 3.4 can be high, so depends on the cardiovascular. Okay, if the triglyceride is too high, more than 4.5, yeah, so this in this patient is 2.1, is still okay, but if more than 4.5, this formula is not accurate. Yeah, so then we use the non-HDL. Yeah, non-HDL, which is TC minus HDL, is the preferred one. Yeah, the non-HDL. Now, why do we call LDL, yeah, bad cholesterol and good cholesterol? This one I think is very basic question lah. Yeah, can somebody answer?
Yes, maybe due to LDL raise risk for heart disease because buildup of cholesterol in arteries.
Yeah, so because LDL transport a lot of cholesterol, yeah, and
Yeah.
LDL will be deposited in the blood vessel, and it causes the atherosclerosis. But why HDL is called good cholesterol?
Good because carried out the cholesterol from other parts to the liver.
Carry from liver or carry to liver?
To liver.
Yeah, so it carries the LDL, yeah, so carry the cholesterol, not LDL, but carry the cholesterol, yeah, from other part peripheral, and then go back to the liver, yeah, go back to the cholesterol receptor, yeah, LDL receptor, yeah. So it helps with the cholesterol metabolism. Yeah. Now, what are the apolipoproteins? Do you know what is apolipoproteins and what are their roles in dyslipidemia?
They're actually protein that helps to solubilize lipid. Basically, they transport the lipid to be metabolized in our body.
Mm-hmm.
So they are proteins.
Okay. So are all the apolipoproteins, they are good or not good?
They're good.
They are good, yeah. Okay, so actually later on you will see there are so many kinds of apolipoprotein. Yeah, some actually are good, some are not good. Yeah, yeah. So if you see the structure of lipoprotein, yeah, for me it looks like for Ferrero Rocher, yeah. So you have the nuts here, yeah. So the one that look like the nuts, they are the apolipoproteins, yeah, apolipoproteins. And then you have the free cholesterol and phospholipid, yeah, the head of the phospholipid. And then we have got triglyceride inside, yeah. So the core of this lipoprotein, the core inside, yeah. So they are full of lipid, yeah, lipoprotein, triglyceride and cholesterol ester, yeah, cholesterol inside is in the ester form because binds to some salts, yeah, so cholesterol ester, yeah. Now about the, so this is another view, yeah. So it's the same thing. So when you have the inside the core, we have the triglyceride, yeah. So we have got apolipoprotein. So you have the different apolipoprotein, like apolipoprotein B 100, yeah, apolipoprotein C, apolipoprotein E, yeah. So this the main one, yeah, being C, B and E, yeah. These are the main one. Okay. So about the lipoprotein, so we have got few kinds. Chylomicron is the one that um, form, yeah, after the food. So it transport actually the food, right, from gut, yeah, from gut after the meal, okay. And then the main carrier of dietary triglyceride, yeah. So this chylomicron is rich of uh, triglyceride, yeah. And then you have the VLDL, not VDL, VLDL, LDL and HDL, right? Now, in all these lipoprotein, we have got the main apolipoprotein here. Yeah, so we have like in chylomicron, you have A1, C2, E. Yeah, and in VLDL and LDL, we see the B100. So LDL have a lot of B100. So the main apolipoprotein is B100. Yeah, and your C2 and E. Now HDL have A1, A2. Yeah, so as you mentioned, yeah. So if you see, because HDL is the good cholesterol. So the A1, A2, they are good apolipoprotein, yeah, especially A1. And the B100 is not good. So the higher we have the B100, the more dangerous it is. Yeah. Similarly with E also not good. Yeah, E and C2 here and B100, it is not good because they belong to VLDL and also chylomicron. Yeah, so they are not good. But B100, this one is belong to LDL and it is really bad. Okay. Now, these are according to the density, diameter, and the content, yeah. And we can see that actually the content of triglyceride is chylomicron and VLDL a lot, yeah. And then, but the content of phospholipid, so LDL, yeah, has a lot with the HDL. Now, types of apolipoprotein, as we mentioned, so like just now A1, A2, yeah, they are within the HDL, yeah. So A1, A2, they are for example, A1, this one I mentioned A1, yeah, is the good one because they activates the LCAT, yeah, lecithin cholesterol acyl transferase, yeah. So where they transfer the cholesterol, yeah, transfer the cholesterol to the liver, okay. So these are the good one, A1, okay. And then you have the B100, uh, triglyceride and cholesterol transport binds to the LDL receptor. Yeah. So actually the LDL receptor will recognize B100. Yeah, B100 will bind to the LDL receptor, and then you have got uh, triglyceride transport activates the LCAT, also the C1. Yeah. This is C2 is actually C2 is good because C2 activates LPL. What is LPL? Lipoprotein lipase. Yeah. So it's a lipase. So lipase can dissociate, hydrolyze the triglyceride into the glycerol and the free fatty acid. Yeah. So the C2 they are good, but C3 is not good because it inhibits the LPL. Yeah, it's not good. And E binds to the LDL receptor and probably also to another specific liver receptor. All right. So apolipoprotein are protein component in the lipoprotein. Their function to maintain integrity of the lipoprotein structure because the structure have to have protein, have to have lipid. Yeah. So their main purpose is to maintain the integrity and then to regulate certain enzymes in the lipoprotein and also to identify receptor. Yeah, just like the LDL receptor. So it's identified by the B100. Now these are the metabolism. I think I no need to. Yeah. So from liver, yeah. So they have the VLDL, yeah. Then intermediate one, and then become LDL, yeah. Oh, from the dietary lipid first. Dietary lipid chylomicron, yeah, transported by chylomicron, and then by the lipoprotein lipase, yeah, the chylomicron become chylomicron remnant, and then after that go into the liver for recycle. Yeah, the HDL also can conduct the cholesterol, bring it back to the liver. Yeah, yeah, and then you have LDL. LDL have uh, receptor in liver and also in the extrahepatic cell. Now the about the LDL receptors, yeah, LDL. Now, so you see this LDL receptor, yeah. LDL receptors are glycoproteins, yeah, that is in every cell, okay, and binds to LDL, which have the ApoB. Just now we see B100, yeah, and E. Inside the cell, the LDL will be broken down, reduced number of LDL receptors. So if we have got reduced number of the receptors, the LDL receptors, yeah, so it will cause hypercholesterolemia because the LDL cannot be broken down. Yeah, the ApoB mutation disturb the binding of LDL with its receptors. Yeah, which can cause family hypercholesterolemia. Yeah, also known as familial defective ApoB. Jadi ApoB is important, yeah, to conduct to bind to the LDL receptors. So when there is a mutation, yeah, it disturbs the binding. Okay, can cause family hypercholesterolemia. Now, what is the importance of all this LDL? Yeah, is because the formation of atheroma. Yeah, I think you are familiar with this atheroma. Yeah, the foam cell, fibroblast. Yeah, and then atherosclerosis. I think I no need um, to read, yeah. So you have the oxidized LDL and then tunica intima, yeah, and then there is also macrophage that will come into play, yeah, and that later on the atheroma can be broken, yeah, broken and then broken down and then cause blood clots, yeah. So they will attract a lot of platelets, and this will also making it more um, more what more plaque, yeah, so more occlusion, okay, more occlusion, and then so it will result in myocardial infarct. Okay, so how the atherosclerosis, yeah, so there's a rupture of the plaque, yeah, okay, forming of blood clot. That's why we give the uh, platelets, yeah, antiplatelets. Okay, if we have got the classification according to WHO. Yeah, you have the normal, type 1, type 2A, 2B, 3, 4, and 5. Yeah. So when we have got the normal one, everything normal. Okay, type 1, what's the difference? Type 1, you have higher total cholesterol, higher triglyceride. Yeah, so you can see the turbidity here. Okay, so because there's a very high in chylomicron, so it means that high in triglyceride, yeah. And type 2, high in LDL. Yeah? Type 3, 2B, 2A, 2B. 2B is also high in VLDL. Because high in VLDL, it means high also in triglyceride, yeah. Yeah. And type 3, IDL. Type 4, high in VLDL. Triglyceride also high. And type 5, it have very high in VLDL, chylomicron, and the triglyceride. So that's why it's very turbid, yeah, very cloudy, yeah, turbid. Okay, the types of dyslipidemia. So I think this is important for us now in the master's level to remember this one. I mean to know about this. Okay, familial hypercholesterolemia. Yeah, where there is genetic defect, reduced numbers of functional LDL receptors. Yeah, it correspond to 2A and 2B just now. Yeah, the one that is in the previous slides. So it has a high risk of CVD. Okay, also there are people who are high, yeah, solely on the triglyceride, yeah, like my mom. My mom has a good LDL, but the TG is high. Okay, possibly single gene defect, yeah, and this is if you see in the prediction, yeah, belong to 4 and 5. Familial combined hyperlipidemia. So combined means, yeah, there are many, they probably can have the high in TG, also high in LDL. Yeah, it's seen in 2A, 2B, 4, and 5. And lipoprotein lipase deficiency. This is you have a deficiency of enzyme. Yeah, so this is the prediction 1, because 1 means that there you have less LPL, so you have a lot of chylomicron, yeah, a lot of triglyceride. And then you have A beta lipoproteinemia, yeah, so inability to synthesize ApoB, okay, and fat soluble vitamin deficiency, neurological deficit. Now, N alpha, yeah, this one N alpha lipoproteinemia, yeah. So this is an ability to synthesize ApoA. So this is ApoA is good, yeah. So we can have the cholesterol ester storage in abnormal sites, and neurological deficit is there. All right, other classification, this is also useful. That is, for example, predominant hypercholesterolemia. So the dominant is the elevated of LDL and VLDL. Yeah. elevated of lipid result, yeah, TC, total cholesterol, plus minus TG, right? Actually, HDL increase, that is good, yeah. Then predominant hypertriglyceride. Okay, so this one is of course, yeah, more in your TG is high, probably it is caused by VLDL, LDL or chylomicron is high. Yeah. Okay, mixed one. Okay, so many people have mixed as well. Yeah, mixed means that they have the familial combined hyperlipidemia with the hypertriglyceride. Yeah, and with this beta lipoproteinemia. Now, how to calculate the CVD risk of Alex, yeah, using Framingham. Okay, we refer to Malaysian CPG, right? So Alex have 44 years old. So 44 is where is 44 here, yeah. 44 means score 5. HDL 1.1. Where's the HDL? HDL 1.1. So it is mean here, right? It is score 1. The TC, total cholesterol 6.2. 6.2 is here, yeah. So what is this? Here mean 2, yeah. And SBP, the systolic blood pressure 148. So 148 is here. So it is 2, yeah. And smoking, the patient is still smoking. So if it is smoking here is 4, yeah. Smoking 4, and then diabetes, and the patient have diabetes, yes, then 3 is granted, yeah, diabetes 3. So the total score 17. Okay, so after we total it up, we get 17. So now we refer to another table. 17, yeah. So 17 means what? Here 17, so it means there is a 29.4%, yeah, of the 10-year risk. All right, so of course this is high, yeah, this is high, 29.4. So if you refer to this one is for female, yeah, for female. So if you refer to this stratification, so he will fall under what? High risk, yeah, high risk because have multiple risk factors confers 10-year risk for CVD more than 20. Just now the patient Alex, yeah, 29. So Alex will be high risk, yeah. And later on, I gave you also a case, yeah, a patient with the chronic renal failure, yeah. So chronic renal failure, it can fall under very high risk or it can fall under high risk, yeah. All right, if they're stage 3 means high risk, stage 4 means very high risk. Okay, how should we treat Alex dyslipidemia? Right? Huh? Lagi ngajar. No. Okay, the target LDL-C level, yeah, the target LDL-C level. So, what is the so very high risk, yeah, this patient is high risk more than 20. So we have the target 2.6, yeah. So you see in this table, this this is from the Malaysian guideline, yeah. So this table, so it means that the LDLC is not uniform, yeah, it depends on the risk. Okay, since this high risk, so we want it to be lower than 2.6, yeah, the target of the LDL-C to initiate drug therapy. Now, after we give drug therapy, we want to know how well, yeah, the achievement. So we want it to reduce to 2.6, lower than 2.6, yeah, or a reduction of more than 50% from baseline, yeah. May I ask, why do you think they are two, yeah? Either it is less than 2.6 or more than 50%. What does it mean? Yes, Ivy?
Hari ini Kiki belajar sama teacher.
Mama aja dulu.
Mama ada yang belajar.
Ivy, you want to try to answer?
Um, I'm not sure.
Uh-huh. So, so it is easy for us to say that, okay, be more less than 2.6. It's easy, right? But why there is another clause above 50% from baseline?
Baseline is too high from 2.6 to reach, is it?
Yes. Yeah, for example, if the patient is, for example, LDL, having LDL of 6, let's say like, yeah. So from 6 to lower down to 2.5, how many have to lower down? From 6 to 2.5, 3.5, yeah. So so within what, within 3 months, for example, yeah. So maybe it's too high, yeah. So we are happy if the patient lower down to less than 3, yeah. For example, 2.7 or 2.8, we think it is they already achieved, yeah. We're quite happy already, yeah. So more generous lah, yeah. So what is this non-HDL? In case of the TG is more than 4.5, so this will be not, we don't use the LDL anymore because it's not accurate, yeah. So we use the non-HDL, yeah. So of course the non-HDL means the LDL plus the VLDL, yeah. So then it will be a bit higher, 3.4, yeah. So this is how you understand the table, yeah. But this is very detailed lah, yeah. You think in the doctor in the clinic they will use all this guideline lah?
No.
Yeah, they will straight away give statin, right?
Yes.
Yeah.
Yeah, they will see the cholesterol level, yeah, from the lab, the reference, yeah, is high, then they straight away give statin, yeah. Of course, this guideline, yeah, is very detailed and theoretical lah, yeah. But we have to, because but guideline has evidence based, right? So we refer to evidence based, yeah. Now the problem with the pharmacist, when we know a lot but we can't do anything lah. The doctor will, yeah. Okay, so now of course the therapeutic lifestyle, yeah, we can read and we know already, yeah. And then you have statin. So when do we start statin? Okay, so the first choice will be statin, right? Yeah, indication for very high and high cardiovascular risk. So like this patient has a high cardiovascular risk, so we should start with statin immediately, yeah. And whether it is immediate, moderate or low risk also, yeah, after. So low risk patient also can be started with statin, but after the trial of therapeutic lifestyle, yeah. If still high, then you use statin, okay. Or if we already use maximum tolerated dose of statin and still high, then we combine with ezetimibe, yeah, combine with ezetimibe. Okay, so or we can combine with the new drug PCSK9 inhibitor. Yeah. For what? For the patient with familial hypercholesterolemia, or when patient failure to achieve LDL. And the last resort, we can also combine statin with fibrate. Yeah, although it is not recommended, but we still can combine. Yeah, for diabetic patients on maximally tolerated statins who have achieved the LDL target but have low HDL and high TG, because fibrates is good for high TG. Yeah, so we can combine, but we have to be very careful. Yeah. And for those who are not who cannot tolerate statin, yeah, for whatever reason, especially for muscle pain, yeah, muscle rhabdomyolysis or yes, and we can use ezetimibe. But ezetimibe is very, very mild, yeah, because it's just to inhibit the absorption of cholesterol. And then the PCSK9 inhibitors, okay, for very high or high CV risk, okay. And fibrates, of course, for very high TG. Yeah, fibrate is good for TG. All right. So these are the mechanism of action of drugs. Yeah. So if you want to just review a bit, yeah. So we have got ezetimibe, yeah, reduce the absorption of cholesterol. Okay, so you can see, you predict, yeah, the if they mechanism is by reducing the absorption. Yeah, so as we know how much 80%, yeah, from our food, then 20% from synthesis, yeah, of the liver. So and we have got so the side effect will be, you know, GI intolerance and all this, yeah, for the absorption. Okay, the resin, there is another resins, yeah, resins that can bind the so can bind the cholesterol, yeah, bind the cholesterol so that it won't be absorbed in the intestine, yeah, so it can be um, excreted, yeah, as in the feces. And then we can have the chylomicron here to increase the lipoprotein lipase, that is the work of fibrates, yeah, fibrates enhance lipoprotein lipase, yeah. Okay, our statin is to decrease synthesis of cholesterol, yeah, decrease the synthesis of cholesterol. And then just now we mentioned about this PCSK9, yeah, which is evolocumab and alirocumab. Okay, that is two. Later I have one slide, yeah, how it actually the mechanism of action, yeah. And then you have got LDL fibrates. Fibrates also reduce secretion of the LDL. Okay. Now this is the mechanism of PCSK9 inhibitors. So those like the worms here, like worms. So this the like this small bubble. Yeah, this one is LDL. Yeah, LDL. So this is the receptor. Yeah, LDL receptor. Yeah, and then the one that look like worms. So so when so these are the PCSK9, yeah. This is the one that look like worms. They are the PCSK9, yeah. And the PCSK9, okay, when the LDL binds to the receptor, so they will be internalized, yeah. And then there will be endocytosis, and there will be digested by lysosome, yeah, digested by lysosome. And some of the receptor will be recycled, yeah, will be recycled. But if there is this PCSK9, yeah, the PCSK9, yeah, will attract the lysosome, yeah, and then the receptor will be destroyed, yeah, will be digested, destroyed. All right. So but if we use the inhibitors, normally the inhibitors, they are the monoclonal antibody, yeah, so they are antibodies, so they will bind first the PCSK9, yeah. When they bind the PCSK9, so there is no more worms, yeah, so the LDL and the receptor very smoothly go inside and there is no worms, yeah, so the receptor will be recycled, yeah, so you end up to have more receptors, yeah, that being recycled. Unlike this one, some of the receptors already being destroyed, yeah, only a few that is being recycled, yeah. So the more receptors we have, the better, because you can capture more LDL, yeah, to be metabolized, right? Understand? Now so these are the medicines, yeah, so we don't have to, you all know about the medicines. They are very not so many, and we always give counseling, yeah, of the medicine, so you all know very well, yeah. And then now these things, yeah, that we have to, how much, what is the dose of statin that we need to give, yeah. So for this patient, so there are two types, yeah, high intensity, moderate intensity, and low intensity, right? So we use the high intensity, yeah. We can reduce the cholesterol by more than 50, yeah. So those are very high one, yeah, high risk. Then we have to give the high intensity, yeah. So the high intensity is atorvastatin 40 to 80, rosuvastatin 20 to 40, and moderate one, so ator 10 to 20, yeah, rosu 5 to 10, and then the others like simvastatin, pravastatin, all belong to the moderate, yeah. And low intensity, yeah, or the very low, simvastatin, pravastatin, lovastatin, fluvastatin, and pitavastatin, yeah, with a very low dose. Yeah. So here you have got a note here. High intensity statin therapy is for patients who are at very high and high risk. Like this Alex is very high risk, yeah, is high risk. So we need to give the, here, we need to give high intensity, yeah. Low intensity statin is generally used for primary prevention after, yeah, TLC and TLC what? Therapeutic life changes, yeah. After the lifestyle changes and following a discussion with the patients, the risk of patient of the risk and benefits. This is for the low intensity. All right. But I think in practice, doctors seldom give straight away high intensity. Yeah, normally doctor will start with a low intensity first. Yeah, at least with a moderate intensity lah, like atorvastatin 10 and 20 are very common, right? Simvastatin 20 to 40, Orosu 5 to 10. Yeah, then only will go to the high intensity. That is the normal practice lah. So what are the counseling points for statins? This one, I think I no need to, yeah, you all expert in counseling already, yeah. Counseling, we need to give them the aim of therapy, how to take the medicine, yeah. So do all statins have to be taken at night?
No.
Oh yeah, only
Only short acting.
yeah, the long acting one can be taken at any time, yeah, the atorvastatin and rosuvastatin. It takes 1 to 3 months. So we need to tell the patients, not straight away you take today and tomorrow you're, because there are some people, yeah, I heard some people, for example, tonight they have to go to party, yeah, they go to party and they will take the statin. Yeah, that is for the normal healthy person, you know. Yeah, so they take the statin after they have the party. That doesn't work like that, right? Yeah, so it takes 1 to 3 months to show the effect. Side effect increase the liver enzyme. So when do we? I think there's a question about the liver enzyme one. Yeah, so we will discuss when the question comes. And risk of diabetes. Yeah, there's a mildly, yeah, normally at the initiation, yeah, mildly increase in blood glucose, but but the benefit definitely is more than the risk. And myopathy, muscle pain, rhabdomyolysis, dark colored urine, yeah, but extremely rare. Okay, drug interactions. This medicine interact with many drugs, so we need to warn the patients about the interaction, but not to tell all the list of interaction. Yeah, the patient will give up. Yeah. All right, how to monitor the therapy? Of course, achievement. Yeah, LDL target check in 3 months. Then after that, every 6 months. Yeah, liver enzyme check 1 to 3 months. Okay, within 1 to 3 months. Yeah, then every 6 months. If tolerated, it is not necessary to check regularly. Symptoms of muscle pain, rhabdomyolysis. Actually, what is rhabdomyolysis? Yeah. Anybody?
It's a muscle injury.
Yeah. So actually there's a muscle breakdown. Yeah. So statin can cause muscle pain, but not necessarily it is a rhabdomyolysis. Yeah. So it can be just myalgia. But rhabdomyolysis is more severe when you have the muscle breakdown. So, and when they have a muscle breakdown, there is what is the danger of this rhabdomyolysis?
Is it something to do with protein energy wasting? No.
Something to do with the kidney. What happened to the kidney?
Perhaps cannot filter the protein anymore, so it can cause AKI and proceed to CKD.
Yeah, it can cause AKI, but actually, if you heard about this, yeah, myoglobin, yeah. So when there is a breakdown of muscle, so there is a lot of myoglobin, yeah. Myo for muscle, yeah. Myoglobin, that is a certain protein, yeah, from the muscles called myoglobin. So the myoglobin is toxic to the kidney, yeah, and can cause nephrotoxicity. And here we have got a lot of creatinine kinase CK, yeah, because CK, if you know creatinine is in the muscle, right? Yeah. So when muscle break down, there are a lot of creatinine will come out, yeah. So the creatinine kinase will be high, yeah. So what are the other disease that creatinine kinase very high? The CK very high. Do you remember? Something to do with the muscle breakdown also.
Is it heart muscle?
Yeah, so there is a heart attack, yeah, MI. So you have the high in CK and CKMB, remember? Yeah, CK and CKMB. So there's another one that is high in CK when you have this symptom or syndrome. What is that? Do you remember? Have you?
Hypothyroidism.
Sorry.
Hypothyroidism.
Hypothyroid. Yeah, I don't know. I am not sure about hypothyroid. But do you know what is neuroleptic malignant disease? NMS, neuroleptic malignant syndrome. Yeah, that is when a patient is cannot tolerate antipsychotic drug. Yeah, especially the oldest form of antipsychotic drug. Yeah, so it will cause this CK will be high, very high. Yeah, neuroleptic malignant syndrome. And then because the neuroleptic malignant syndrome, yeah, the patient will have also high fever. Okay. And drug interactions, compliance, adherence to medicines, and lifestyle changes. This our monitoring, yeah, whether the patient can comply or not. Okay, our case continuation, Alex was prescribed atorvastatin 20 milligram. After 3 months, he has another appointment at the KK. He has tried to quit smoking, but has not been very successful. He claims that he takes his medicine regularly, which are lisinopril, atorvast, and metformin. Yeah, and then he claims that he adheres to low carbohydrate, low saturated fats, and sodium salts. His body weight has gone down to 65 kg, but now it has gone up again to 68. Yeah. Exercise, he claims to have brisk walk around his housing area about 30 to 60 minutes on weekends. Okay. Is it enough? This exercise 30 to 60 minutes on weekends only. Enough?
No.
No, according to guideline, it must be at least
3 days.
3 days,
Five.
3 days in a week, yeah. And 3 days if possible, yeah, should not like you have to have maybe 3 days in a consecutive, yes, or 3 days but every other day that is okay also, yeah, but should not be more than 2 days, like for example like Monday and then after that jump to Thursday, so that is not good enough, yeah, so it must be more regular. Now case continuation, vital signs, the BP has gone down a bit, yeah, and pulse, respiratory rate, okay, and then the sodium, potassium now is normal, but potassium now is tend to be high, yeah, and chloride is a typo error, and then you have all these are okay, and then the fasting blood glucose now is 6.5, okay, almost achieving, yeah, almost here, the 7.5, yeah, okay, almost, yeah, on the way, okay, but the total cholesterol is still high, HDL, LDL, the TG is also still high. So the AST, ALT seems to increase, yeah, from last time. Last time only 20 something, now increased to 40 something, 50 something. So, so what does it alert us or not? So do we achieve the target for this patient or not? Total cholesterol 5.5, HDL, LDL 3.5. Do we achieve the target 3.5? Initially, he has
No.
got 5.2, I think, yeah. Initially, 5.6 or 5.2, I forgot. So now the patient has total cholesterol 5.5, LDL 3.5. Before it is what? Let me check the previous one.
I think it's 4.1.
No, the total cholesterol. Long way to go.
6.2.
6.2. So, and then there is 4.1, is it? The LDL.
LDL is 4.1.
Yeah, so we not if 50% mean around 2, right? So 2.6 like that, achieve 2.6, below 2.6, yeah, we are quite happy. But for this patient, not yet, right? This patient is still 3.5, yeah, so still above, so not achieving yet. So what do you think, what can you blame on? Because the statin is, this one atorvastatin 20 milligram, is it okay? According to our guideline, the atorvastatin must be high, right? high
High
intensity. Yeah,
intensity.
must be 40 to 80, but this patient only 20. Okay. So what do you think? Can we increase the statin?
Yes.
But the AST, ALT bit increased
Uh-uh.
already, yeah?
The patient is still smoking.
Yeah, still smoking. So we have to ask the patient to stop smoking. Okay. In view of that his ALT and AST have slightly raised, can we safely continue statin? Okay. So our answer in Malaysian CPG 5th edition, yeah, stop statin only when ALT, AST raised 3 times higher. Yeah. So the higher one is 40, right? What is the 40? Yeah, so 3 times higher means 120. So this patient is still 45. Yeah, still okay. So we still can continue the statin. Other literature said 5 times higher. Okay, so we follow Malaysian guideline now because since we are in Malaysia, yeah. So we have to weigh the risk and benefit. Okay, so whether we want to increase the statin or we maintain the statin and plus ezetimibe, what do you think? Should we increase the statin or should we combine
We
with
can
ezetimibe?
for Atorva's 40.
40, yeah.
Mm-hmm.
Okay, but how about the problem with the ALT AST?
Because it was just slightly higher, 52 and 40 something.
Okay,
Much.
how about the option to try to combine with ezetimibe?
Um, acetamol. Because acetamide, the combination is with atorvastatin, I think. Acetamide.
There is a combined one with simvastatin, right? There's a combination with simvastatin, but any
Yeah,
statin.
140. Yes.
Hmm. But I think there's also combination atorvastatin and ezetimibe. I think I forgot, if not mistaken. Yeah.
In the
Okay.
blue
So
book, no, we have CMOS and acetamide only.
okay. So what option is available to optimize the dyslipidemia therapy? First option, of course, to increase the atorvastatin to 40 and monitor the liver enzymes for 1 month. Yeah, in 1 month time. So if the liver enzyme keep increasing, so we have to, probably lower down the statin and plus the ezetimibe. Yeah, and combine, or the second one is to we use the combination therapy with other medicines like statin with ezetimibe. Yeah, or if the TG is high, then we can use statin and niacin, but not for this patient lah. Yeah, or statin with PCSK, sorry, not PCKS, PCSK9. Yeah, or statin with omega 3, PCSK. Statin with omega 3, but omega 3 is very weak lah. Yeah. Statin with fibrate in general we avoid if necessary. Use non. Kalau if we need to use statin with fibrate, yeah, it is better to choose fenofibrate and avoid gemfibrozil. Okay, both have these advantages and disadvantages as we have described in the lecture. So there is no fast and hard rule, hard and fast rule. So you can try to increase the dose and then monitor the liver enzyme, yeah, or we straight away maintain the statin plus ezetimibe, yeah, and then probably we can, we don't know, yeah. I mean, we don't know if we can do the RCT for this, compare the two group, yeah. But the increase in liver enzymes is really individual. Yeah, not everybody will have, right? It's very individual. All right, I think this is, yeah, the end for this part, yeah, and then I have another case. Any question up to here?
No.
No, yeah. So
No.
we can look at a few slides only. The other one, yeah, a bit more advanced one. Okay. So now, Michael, a 51-year-old man with CKD, yeah, due to polycystic kidney disease. He has no history of tobacco use or diabetes, but is treated for hypertension. He is very active and works in an insurance company as an agent. He admits that he does not exercise regularly, but he does follow healthy diet recommendation and maintains a normal BMI. His recent lab test, EGFR 42, yeah, and then total cholesterol 44.8, HDL1, LDL 2.6, TG 2.6, A1C 6.8, yeah, sorry, 6.8, not 6/8. Okay, BP 126/68. So it's still okay, yeah, there's no hypertension. All right, so what is Michael's ASV? So ASCVD, what is ASCVD? Atherosclerotic cardiovascular disease, yeah. Risk and his lipid panel results. So we need to have to know the risk. So here refer to guideline, yeah, with CKD, yeah, and this patient has stage 3B because the EGFR is 42, yeah, 42, so is stage 3B. Now patient with this stage, yeah, GFR 30 to 60, so it is under um, risk of high risk, yeah, high risk. So we need to start when the LDL cholesterol is more than 2.6, yeah, for this patient. Right. Now if we want to start this patient with statin, so this is the treatment recommendation, yeah. So if the age is more than 50 and the EGFR more than 60, then we can start statin. Okay, so if younger, a bit younger, yeah, with have a kidney transplant and have diabetes mellitus, stroke, etc. Yeah, so we also need to start with statin. Yeah, but if the patient is dialysis, then no initiation of therapy. So no need to initiate the therapy like that. Yeah. So atorvastatin, fluvastatin. So here we have got different table. This is from Malaysian guideline. Yeah, so you have for example, for patient with GFR less than 60, yeah, so we actually limit the dose of atorvastatin to 20. Yeah, the others like simvastatin to 40. Okay, and with this is why I put two, because there are two different literature, yeah, and two different. For example, for here, if you have got creatinine clearance 30 to 650, you can the atorvastatin can go up to 80 actually, yeah, yeah. So even if the creatinine clearance is less than 15, still can go up to 80, yeah. But the fluvastatin, lovastatin, they all reduce, yeah, reduced by half. Now, we have got case 2, Amina, 63-year-old woman diagnosed with dyslipidemia 7 months ago and is in clinic for follow-up. She has a history of gout, yeah, chronic non-ischemic heart failure, yeah, the EF is 26%. Diabetes, diet control, as well as 20 pack year smoking history, but quit 5 years ago. Vital signs, yeah, BP okay, HDL 1.7 is quite high, you know, and LDL 2.6, TG 1.1, TC 4.8. Her medication include lisinopril, furosemide, metoprolol-succinate, and simvastatin. So simvastatin already started. Okay, Amina is admitted to hospital with AF, atrial fibrillation, and is started on amiodarone and apixaban. Is there any pharmaceutical care issue in this case? What is your recommendation? What do you think? Anybody want to try?
The amiodarone will increase the simvastatin concentration. So may switch to, I mean, maybe can reduce the simvastatin to 20 mg only.
20, yeah. So let's see. Okay. So about the drug interaction, okay, with amiodarone, simvastatin with amiodarone, do not exceed 20. Yeah. So do not exceed 20 daily. All right. So you are correct. Yeah, Ivy. You suggest the doctor to lower it down to 20. All right. Now, case 3, Ali, 46-year-old male with history of hypertension and T2DM. He presented to his primary care physician with a chief complaint of abdominal pain that began 2 days ago and radiated to his mid-back. He also has some vomiting. All his vital signs were within normal limits. On physical exam, he has tenderness over his abdominal area that is more severe in epigastric region. Pertinent laboratory value A1C 13.6. Yeah, it's very high. Following lipid panel TC 12.1, HDL 0.78, TG 21.2. Yeah, very high, right? LDL unable to be calculated because TG is too high. Yeah, it's not accurate. Yeah, when TG more than 4.5. Okay, amylase 3.325, lipase 3000 something. Yeah, and he was diagnosed with acute pancreatitis. What would be appropriate treatment for his lipidemia? So, what do you think? What is the relation between pancreatitis and high TG? So when there is a very high TG, yeah, there is a risk to develop pancreatitis. Yeah. So most probably because the pancreas um has to secrete a lot of lipase, right? Because you need more lipase to break down, yeah, the TG. So you have got very high lipase here. Hmm? Now, option, we give a fibrate because high in TG, yeah, plus omega-3 fatty acid to lower down the TG, then only give a statin. Yeah. You give first fibrate and omega-3, lower down first to PG, then only we give the statin. Okay, or we straight away combine statin plus a fibrate. Yeah, but we need to avoid gemfibrozil. Recommend using fenofibrate if the combination deemed to be necessary. And we need to get baseline creatinine clearance and CK. Yeah, because why we need to get the baseline creatinine clearance and also CK? Why? Because
To see patients, is it high risk or not?
high risk of
It's for clearance.
Cardiovascular.
rhabdomyolysis. Yeah. So because rhabdomyolysis is higher, the risk is higher when you have the kidney disease, right? If you have CKD, kidney disease, so it will be higher, the risk. And also the CK, why we want to get the baseline CK, right? Because after a few months, you take again, or if the patient have muscle pain, then you take again the CK, you can sort of compare, yeah, between the baseline and the now, because there is a risk to develop rhabdomyolysis when you combine statin and fibrate, any fibrate. If you're unlucky, you can get it. Okay, so there's a few slides for you to learn about new drug. Yeah, the new drug. So there's the first one. There are three classes that I want to present to you. Yeah, so the first one is lomitapide. Yeah, lomitapide blocks microsomal triglyceride protein. Yeah, what is we call MTP, found in the lumen of endoplasmic reticulum. Okay, so in the cell you have endoplasmic reticulum. Yeah, then you can find the microsomal triglyceride protein. Okay, this prevents synthesis of chylomicron in the erythrocyte. MTP helps assembly of TG cholesterol and ApoB48 into chylomicron, right? So if you block the MTP, yeah, you block the synthesis of chylomicron. And synthesis of VLDL in the hepatocytes also being blocked. Yeah. Because these both VLDL and chylomicron, they are rich in TG. Yeah. As a consequence, production of LDL is reduced as well. Yeah. Okay. Because from VLDL, yeah, you can produce the LDL. Yeah. So when VLDL reduce, you also reduce the LDL. All right. So these are dietary source, okay, liver source. So approved as an adjunct treatment in patients with homozygous family hyperlipidemia. Okay. So hyperlipidemia, ya, di mana terdapat homozygous. Okay. Now, ADR, GI symptoms, nausea, vomiting, dyspepsia, constipation, flatulence, also elevated transaminase, just now the LTST, and also hepatic steatosis. Cek, ya, setelah 3 bulan initially, ya, setelah itu, ya, if more, every 3 months, ya, if more than 5 times the upper limit, yeah, normal, then you do not decrease to less than 3 times within 4 weeks. Yeah, meaning that the elevated transaminase, yeah, if they do not decrease to less than 3 times, yeah, within 4 weeks, really within 1 month. After 1 month, you check again. If the liver enzyme is still high, so you stop the medicine. Yeah, dose initially 5 milligram OD, increased after 2 weeks to 10, then titrated upwards in the interval of 6 weeks to 20. Then at 10 weeks to 40 milligram, and after 14 weeks to a maximum of 60. Yeah, a Lomitapide is a substrate of CYP3A4, so we must be aware of it, yeah, especially for the interaction involving CYP3A4. Okay, another drug, yeah, mipomersen. Mipomersen is an antisense oligonucleotide targeted to human mRNA for ApoB 100. Yeah, luckily just now you see already what is ApoB 100. Yeah, ApoB 100 a lot in the, you find it a lot in the LDL. Yeah, so mipomersen is complementary to the coding region of the mRNA for ApoB 100 and binds to Watson and Crick base pairing. Yeah, that is the guanine, cytosine, adenine, thymine. Yeah, so they will bind the mipomersen. So this RNase, yeah, H mediated uh, degradation of conjugate mRNA, thereby inhibiting translation of the ApoB11, ApoB 100. Yeah. Okay, this action leads to reduced ApoB synthesis, the structural core for all atherogenic lipids. So, as I said, the ApoB here, they want to reduce it. Okay, so the ApoB mRNA, okay, DNA transcription. So, antisense, yeah, so antisense oligonucleotide like mipomersen. Apa itu ya? Mipomersen, okay. Right. So it will decrease the mRNA degradation. Yeah. So it will affect the LDL and VLDL assembly. So mechanism of action just now, yeah. So mipomersen. So you can read this. Yeah, it's quite easy to read. All right. So the last one, PCSK9. I think this one, oh no, not the second before last. Yeah, but this one I already explained. So no need to read again. Yeah, the same thing. Yeah. The only thing clinically used adjunct to diet and maximally tolerated statin therapy in patients with heterozygous family hyperlipidemia. The first one just now, yeah, is for the homozygous. This one is for heterozygous. Yeah. Adjunct to LDL apheresis to for homozygous family familial hypercholesterolemia. So adjunct to LDL apheresis, you know what is LDL apheresis? Yeah, so that is technology, yeah, to actually make to take away the LDL, yeah, from the blood. LDL apheresis, yeah, like a hemodialysis like that. Okay, patients who cannot tolerate statins, dosage, yeah, all still subcutaneous, yeah, both alirocumab and evolocumab, they are subcutaneous injection, yeah, like the diabetes as well. Side effect, ya, nasopharyngitis, URTI, influenza, back pain, etc., hypersensitivity, also raised transaminase, ya, myalgia, and neurocognitive event. Okay, and there's the last one is CETP inhibitors. What is CETP? CETP is cholesterol ester transfer protein. Yeah, transfer cholesterol from HDL to VLDL and LDL in exchange with TG. So the cholesterol that being transported by HDL, yeah, HDL can deposit the cholesterol to the liver, or they also can pass it to the LDL. If yeah, so HDL is very generous. It can pass the cholesterol to the cell also, yeah, HDL and VLDL. So CETP inhibitors increase HDL and reduce LDL and VLDL. 4 candidates have been developed. So torcetrapib increases mortality. Dacetrapib and evacetrapib had no impact on CVD events, so they have been abandoned. Yeah, the only candidate now is anacetrapib. Okay, so these are the trial. No, the mechanism. Sorry, not the trial. The mechanism. Yeah. So just now the CETP. Yeah, CETP can what do you call this? Deliver, yeah, the some of the cholesterol to the VLDL, yeah, to the LDL. Okay. And this one, because they block, yeah, so the anacetrapib block this. So there will be less, yeah, less cholesterol, yeah, being channeled to this, yeah, already cholesterol rich particle. Right? Okay, so these are the last slides. Any question? Yes or no?
No.
No, yeah, quite easy, yeah. So the next class, yeah, Saturday. Can we do Saturday in the afternoon?
Can.
Yeah, maybe around 3 p.m. your time, 3 to 5 p.m.
Yeah, can, sir.
Yeah, can, yeah. So I'll try, we will do the diabetes now. Since diabetes actually, what do you want to learn about diabetes? Do you want to learn more about the insulin?
Yeah, maybe more of the insulin, those adjustments.
Okay, so the dosing of insulin, yeah. Okay, I'll put in a few reading material about that. Okay.
Alright.
Sir,
Huh?
just now the second set of slide is not in the.
Oh, I have not uploaded. Okay, I'll upload tonight. Yeah.
Yeah.